Good morning, everyone. Thank you for coming again to another exciting half day of our program. To get things started, we're going to have Mahmoud Ibrahim speak about metformin and diabetes prevention. And if you noticed prior, each of the speakers for this first section are going to be speaking for about 15 minutes, and then there's going to be a little debate at the end. So we're going to let them speak for their 15 minutes, and then you can kind of chime in with some questions and comments as well. And all right, I will let you take it away, sir.
Thank you, Amy. Good morning, everyone. It's me again. Actually, we are talking about the possible role of the most common diabetes medications in the so-called diabetes prevention. So talking about metformin, I'd like to start with the conclusion. For the management of type 2 diabetes or pre-diabetes or even people at high risk of developing type 2 diabetes, lifestyle is actually the cornerstone. And by lifestyle, I mean diet, physical activity, especially the physical activity. When it came to the medications, I do believe that metformin should be, it was, and it should be and remain the main foundation in the management of type 2 diabetes and in the prevention of diabetes. So metformin and diabetes prevention are actually very clear in most of the diabetes prevention studies. We are talking about diabetes prevention program, Chinese study, and the Indian DBB. I will be focusing a little on the DBB. And as you can see here, we saw this slide many times along the last 2 days. Yes, metformin actually could reduce the prevalence of type 2 diabetes by 31%. Again, metformin is inferior to the physical activity and diet, but still it is superior to any other medication and also superior to the placebo. So this is actually an exciting slide because if you can see here the incidence of diabetes per year, you will find for the placebo, we are talking about 11%. For the metformin, it's approaching 8%, while in the lifestyle, we are talking about almost 5%. The reduction in incidence, as we already mentioned, for the metformin, it is 31% compared to 58% with the lifestyle. For the number of people needed to be treated to prevent type 2 diabetes, it's about 14 person with diabetes in metformin group compared to about 7 with the lifestyle method. So what about the follow-up for the DBB? As you can see here, after 10 years, still 52% of placebo participants have diabetes compared to 47% of metformin participants and 42% of lifestyle participants. What happened after 15 years, as you can see here, 62% of placebo candidates actually developed diabetes compared to 56% in the metformin group and 55% lifestyle. What is the message here? The message here is that metformin is more or less equal to the lifestyle after 15 years. So, what is the best medication to prevent type 2 diabetes? Of course, this is actually a debatable issue. But we are talking, I'm sorry, I didn't include anything about SGLT2s, but it will be covered by ABA, as I remember, or beta, I don't know. But anyway, if we're talking about the efficacy, with the exception of the TZDs, metformin proved to be very effective in the prevention of type 2 diabetes. Longer-term data, and this is a unique about metformin. Metformin probably is the only medication which we have longer-term data about diabetes prevention. For the adverse event, of course, metformin is relatively safe compared to the other drugs. Much more important, the cost. See the cost here. The metformin, you can tell it's like a zero cost because it could cost up to $4 compared to the GLP-1 or alpha-glucosidase inhibitor or even thiazolidinediones. So cost-wise, metformin should be superior to anything. This slide actually is developed by the American Association of Clinical Endocrinology, and it's a very nice illustration to help you how to choose the proper medication for type 2 diabetes. And as you can see here, metformin is actually very safe, with the exception of little contraindication in cases of renal impairment. But I will tell you very soon what happened after publishing this slide. So compared to the other drugs, even for the GLP-1 agonist, you can find that metformin probably is the safest of this group of anti-diabetic medications. Actually, people like my friend Peter are trying to promote the notion that GLP-1 is a magic drug simply because it worked maybe on 6 out of the 8 diabetes subjects. And this is while they claim that metformin is actually working only by reducing the hepatic glucose production. And this is a fallacy. Because as you can see here, metformin is very good on the so-called inter-organ communication to regulate the blood glucose. So it improves the communication between the gut, the brain, and the liver. Moreover, if you can look deeply on the mechanisms of work of metformin as an anti-diabetic drug, you can find, for example, for the hyperglycemia, it works good. For the insulin resistance, it improves the insulin sensitivity. The same for hyperinsulinemia. Good impact on the abdominal obesity. May have positive effect on dyslipidemia. Almost no effect on blood pressure, and so on. So again, metformin is not just working by reducing the hepatic glucose production. There is so many mechanisms beyond this hepatic glucose production. Moreover, I talked to you about the limitations of the use of metformin among people with renal impairment. But what is really recent? Many publications are talking now, like this for Inzuki, published in 2018, I believe, 2017, I'm sorry. Now, you can use metformin with renal impairment and the glomerular filtration rate down to 30 micrograms. And again, this is another recently published paper on January 2018, indicating clearly that metformin could even work with people with end-stage renal impairment. So again, metformin seems to be almost the safest anti-diabetes drug, either for treatment of type 2 diabetes or for prevention in cases of prediabetes. And let me end this short presentation by a very short statement about the type of medication you should use. Because I remember maybe 35 years ago when we were just medical students, we were studying pharmacology in the famous Goodman and Gilman pharmacology book. And the Goodman and the Gilmans actually having a very nice quote I never forget for more than 35 years. Don't be the first to use the next or the last to leave the bust. Thank you so much.
Have Abraham Thomas come up. Take it away, sir.
Okay. Thank you. So I have no disclosures. And what I'd like to show you is, as we look at GLP-1 agents and prediabetes, unfortunately, there's not a lot of clinical data as there is with metformin. But some of the promise that was initially looked at was promise in animal studies, which I have to be honest has not been borne out when we look at it further in humans. There's not really a good way of assessing this in humans directly as in animals. Now, this is an example of a study that's now about 8 years old where they looked at rats. And just so people know, rats' normal kind of growth pattern is they increase weight and they grow longer throughout their lifespan. And if you give them food, they will increase their weight. If you restrict their food, they don't grow as fast. And in this study, what they did was they looked at the diabetes incidence in rats that got no restriction. These were the control. They restricted their caloric intake or gave them liraglutide, and they followed them for 6 months. So this dark line is the control rats. This dotted line is the liraglutide, and this is the restricted in terms of diet. And what you can see is, if you look at things like their weight, now this is just the diabetes incidence first, so you can see the diabetes incidence increases. It's kind of the opposite of the way we normally look at these graphs, but these rats increase in the control group, less so in the liraglutide, and caloric restrictions well known in rodents to actually decrease the chance of getting diabetes incidence. And then if you looked again, over a longer period of time, beyond the 6 months in here, these groups start to come closer together over time. So it looks like there's a delay with the restricted diet or liraglutide compared to the control group. But over the course of their lifespan, and remember, rodents have a year to 2 year lifespan, so these actually are quite elderly as we get here. You know, they're teenagers usually when they're about 6 or 8 weeks old. Now, if you look at fasting blood glucose, you can see by restricting the diet or taking liraglutide, the fasting blood glucose did not really go up much. But if you let them eat as they would be without any restrictions, their blood glucose went up, which relates to their development of the diabetes. Now, if you look at energy intake, they start about 2 months. The group that got the liraglutide and the calorie restriction, their energy intake kind of rose, but then plateaued. The energy intake of the non-restricted rodents stayed about the same and steadily increased. And you want to make sure when you're looking at this, you're not affecting their overall state. They're not unhealthy. And you can see the body weight went much slower in the non-calorie restricted or liraglutide group. But by the end of 6 months, they're pretty comparable. So there was no permanent harm by doing this to these rodents as an explanation. So this is, I think, the interesting part is then they took pancreas sections. And on this side are the control groups. On this side is the restricted group. And this side is the liraglutide group. This is just the regular staining of the islets. This is a staining for insulin. And this is a staining for glucagon. And you can see by restricting calories, the brown part is what's actually staining for insulin in the islets. And over here in the liraglutide group, much more than you can see in these rodents that eventually would develop diabetes. And you also see preservation of glucagon as well in this. So this was type of data that was actually somewhat promising that maybe there's an impact of GLP-1 agonists in preserving pancreatic beta cells. Now, this is a different study, and we'll just focus on a few things, and this is kind of ingenious, is what they did was they took rats and they injected human islets into them. And the reason that the neat thing about putting human islets is then they can actually track which ones are human versus the rat's native islets, and they put this under the skin and they could look at the differences. So just to show you, this is a stain for insulin, this is a stain for glucagon, and this is a stain for somatomedin. When they give the graft early, they see actually more of these islets taking than versus if they're adult. But then they looked at what's the impact of a GLP-1 agent on these islet cells. So this, again, is the juvenile part is on this side. The adult is here. The black is a group that got the phosphate buffered saline, so essentially a placebo. And this is Ascendant 4, which is the GLP-1 agonist. And you can see in this picture, which I think is what highlights it best, more of these red stains for insulin in the islets that received the GLP-1 agent versus the placebo. And if you look at the juveniles, as shown earlier, the juveniles actually retain more of these islets. At every stage in their lifespan here, if you look at this, the ones that got the GLP-1 agent actually have more labeled cells in the islets that are actively dividing. Now let's switch to some human studies. And this is a study from about 2010. They looked at lifestyle and body weight in obese subjects with and without prediabetes. So unfortunately, it's not a pure impaired glucose tolerance or impaired fasting glucose study. Placebos in the white. The black triangles are the exenatide. And you can see over the course of 24 weeks, a fairly significant drop in weight, about 4 kilos between these two groups. And when we looked further at the number of subjects in this study, there were about 152 that were randomized. 25% of these subjects had impaired glucose tolerance or impaired fasting tolerance. And I don't think in many of our studies we're not really specifying which group is getting which treatment, and that might have some implications because some of the pathogenesis for IGT, if you're looking at the response to a glucose load versus fasting, may have some differences that maybe are important if we looked at this further in terms of the drugs that we're using. But here's the exenatide loss, 5.1 kilos versus 1.6 kilos. And this was related to a calorie deficit of about 450 calories versus 387. And at the end of the study, they looked at how many people had normalized who had IGT or IFT, and 77% of those who had impaired glucose tolerance normalized their glucoses, and only 56% of the placebo. In another study, we're using liraglutide, and this was in people with IFG or impaired glucose tolerance. They did a 14-week study that was double-blind randomized. I always have to say, though, I think it's a little tough to randomize in a blinded fashion GLP-1 agonist because of the GI symptoms compared to placebo. So even though they do this, I sometimes wonder if these subjects actually know what they're getting. So 24 individuals got liraglutide at a higher dose at 1.8 milligrams, and 27 had placebo, and then they were, as after randomization, the liraglutide arm lost twice as much weight as those assigned to placebo, and 75% of the participants in the liraglutide arm achieved a normal fasting plasma glucose. And this is just showing you how much weight they lost. So of all the subjects in the study, 88% on liraglutide lost at least 5% of their weight versus 22%. And if you go down to the most extreme, the 10% of the weight, 17% of the subjects in the liraglutide arm lost weight versus 0 in the placebo arm. And then if you look at a different measure in this study of how what's called a steady state plasma glucose, and this is sometimes people say simpler. I actually think it's just as complicated. It's another way of looking at insulin sensitivity. What they do is they give somatostatin, and then they give glucose, and they see how much the glucose rises. So actually having a lower glucose means that you're more insulin sensitive. So before and after 14 weeks of treatment, the placebo, there is no difference. At the end of 14 weeks, the liraglutide arm had a significantly lower steady state plasma glucose, suggesting that they're actually much more insulin sensitive. And this is another study that looked at 49 individuals with either IFG, IGT, or combination of both. They also had a 14-week study, and weight loss was much more significant in the liraglutide arm, 7.7% versus 3.9%. And when they looked at the insulin response after a glucose infusion, it was decreased 7% in the placebo arm, but increased 34% in the liraglutide arm. And that somewhat suggests that maybe there's some recovery of beta cell secretion. We do see this with weight loss, but we don't know is this an independent effect of the GLP-1 beyond weight loss. But in the study, when they looked at it and they tried to account for the weight loss, it seemed that the insulin secretion rate was still enhanced. This is just to show you this data. So this is the insulin secretion rate pre and post liraglutide or placebo. So this is pre. And you can see there is really no difference before the study, at the start of the study, before anyone received liraglutide or placebo, in terms of insulin secretion rate in response to increasing glucose infusion levels. But at the end of the study, you can see that the group that was the placebo, they are actually, if you follow them out, they're not actually having as much of an insulin secretion versus the ones that got liraglutide, which remarkably increased their insulin for lower levels of glucose. So to get a response of having an insulin secretion rate at this level, you really have to have a glucose that's well in the hyperglycemic range. Now, this is an additional study that looked at liraglutide dosing, and most of these studies were done during kind of the registration and workup for this to be approved. And there are 4 different doses of liraglutide, which are in the different blue triangles here. There's Orlistat and placebo. And what this did was it followed subjects who were randomized to 52 weeks. And as you can see, the liraglutide arms and even the Orlistat arm, there was a drop in weight. And the placebo even has a drop in weight. You know, there's this finding that if you're in a study, you start to do the things you should normally, and even placebo arms lose weight. At the end of 52 weeks, people were randomized either liraglutide or Orlistat, and they were followed out in terms of their weight and relatively stable here. Improvement in blood pressure, though not significantly different, diastolic blood pressure, and there was a significant change in pulse rate in the group that had Orlistat actually had a drop in pulse rate. Liraglutide stayed the same. So when we look at people who are in this study who had prediabetes, which is this upper left, the placebo is the gray, Orlistat's the green, and these blue colors are the liraglutide doses. At randomization, similar rates of prediabetes. At year 1, so this is at the end of the period before they do the crossover to either liraglutide or Orlistat, many less individuals in these higher doses of liraglutide did not have prediabetes at this time. And if you look at year 2, which is really at the end of the study, the groups that had the liraglutide versus the Orlistat actually had a lower number of subjects with diabetes. Problem with many of these studies, as Peter mentioned on Friday in his talk, is you don't know what really the impact of the drug is until you take people off of the drug, and that doesn't always happen in these studies. So Peter actually talked a little about scale on Friday, but this is a randomized double-blind placebo-controlled trial, and people had prediabetes and a BMI of greater than 27 or 30. This is the largest trial of the group that I will talk about. A little over 2,200 subjects were randomized to liraglutide or placebo. There were 2 subjects of liraglutide essentially for every subject that had placebo. And at the end of the study, 40% of the liraglutide subjects and 55% of placebo subjects finished the study. That's a problem, and we'll go into it when we show the data slides. By week 160, 2% of the liraglutide group developed diabetes versus 6% in the placebo group. So this is the data here, and the liraglutide is red, the placebo is in blue. And if we're looking at the number of subjects that actually developed diabetes, you can see the placebo group, that increases over time. This last part is kind of the washout period. And this is just another way of looking at this as well. If you look at fasting glucose, the placebo group had a higher fasting glucose than the liraglutide group, and also had a relative change in fasting insulin over time. So this was actually lower in the liraglutide group. Now, if you look at the weight, you can see the weight is lower in the liraglutide group throughout the study. When the drug is stopped, the weight starts to increase in the liraglutide group. It's relatively stable in the placebo group. And this just shows you the number of subjects that lost weight in at least 5%, which is greater in liraglutide, or 10%, or even 15% of their body weight, which is a pretty dramatic amount. So let me just say the one thing I was going to mention is, remember, almost half of a little less than half of the subjects dropped out of the study for a variety of reasons. So what do you do with the data? There's multiple reasons why people drop out of a study when there's weight loss involved. One is they're not losing weight. 2 are symptoms. So most people, as you can see, lose weight in the initial part of a study. What they did was a method to analyze this data called last observation carried forward. So if someone dropped out of the study here and lost this much weight, we don't know what would have happened to them throughout the study, so we carry this value all the way to the end. There are multiple ways of looking at this and analyzing it to try and get at the truth, but that is always a problem with any studies that involve weight loss, is we don't really know unless people stay in the study, right? And this is both for being treated with the agent, but also placebo. If you're in a study that has weight loss and you're getting placebo and you're not losing any weight, you probably drop out as well, which is a problem. So that makes it sometimes difficult to interpret data for these really long studies of what's happened. So in summary, animal models have shown promise of GLP-1 increasing beta cell mass. We don't have a good way of looking at this in humans. We don't think it actually happens the same way in humans. The human studies, as I mentioned, have not confirmed this. GLP-1 agents decrease development of diabetes in subjects with IGT and IFG, but we don't know if it's long-lasting. And in some of these studies, we don't know what happens when the drug is stopped. And weight loss probably does play an important role in the prevention of diabetes, but it's probably not the only role. Is that one study showed you there's a dramatic increase in insulin secretion in response to glucose. And there are other effects on the pancreas with GLP-1 treatment that also may play a role in the diabetes, such as the impact on the glucagon cells as well. So thank you for your attention.
Thank you, Dr. Thomas. And next, we will have our speaker, Alexandra Migdal, speaking on anti-obesity agents. Take it away.
All right. Good morning, everyone. So I'm going to spend the next few minutes talking to you about the role of anti-obesity medications in diabetes prevention. So I'd like to start with this slide because I think it just gives a good overview of various mechanisms of action of diabetes and weight loss medications that have the potential to delay the onset of diabetes. And for the purposes of this talk, I'm going to be focusing on these 4 agents here. So for those of you who don't prescribe anti-obesity medications or aren't familiar with the indications, I've listed them here. So they're approved for use in combination with a comprehensive lifestyle intervention in patients with a BMI greater than 30 without comorbidities or a BMI greater than 27 in patients who have comorbidities of obesity. And it's important when you have patients on these medications to make sure that you're really looking at the efficacy and weighing the pros and cons of continuing treatment. And the prescribing guidelines say that if a patient loses at least 5% of their body weight at 12 weeks and they're tolerating it well without any side effects, go ahead and continue it on. If a patient hasn't lost 5% of their body weight at the 3-month time point, the recommendations actually are to stop the medication because it's unlikely that they are going to respond. And in that case, the potential for side effects maybe outweighs any potential benefit. And this study was published a few years ago. I found it pretty striking when it came out, so I wanted to share it with you guys. This looks at the utilization of pharmacotherapy. So first we have here in red, these are patients with type 2 diabetes for whom treatment is indicated. And in green, you have the patients who are actually receiving treatment. So for type 2 diabetes, we're pretty good about getting patients on medications. What happens when we look at obesity? So you can see that there's this huge discrepancy for whom treatment is actually indicated and who's actually receiving pharmacotherapy. In fact, only 2% of obese Americans who are eligible for treatment with these medications are receiving them. So because our patients are not getting these medications, there's a variety of reasons for that. People aren't comfortable prescribing them. There's issues with insurance coverage and so on and so forth. For my talk, what I'm going to do is I'm going to go through each agent and present about 1 slide on the mechanism of action, dosing, side effects, and then highlight some of the pivotal trials that have come out. So to start, we'll talk about Orlistat, also known as Xenical or Ally. It inhibits pancreatic lipase and reduces fat absorption after a meal. It's the only peripherally acting agent I'm going to talk about. The other ones have more central effects on satiety and cravings. It's dosed 3 times a day. There's an over-the-counter version and a prescription strength that's available. This medication is really hard for patients to tolerate. They have oily stool, spotting, fecal urgency. There's issues with vitamin deficiencies and interference with other medications. So I don't have really any patients who like this medication or use it. But anyway, I'll show you the data. So the Zendo study was the main study that looked at use of Orlistat in the prevention of diabetes. They enrolled 3,000 patients. Most of them had normal glucose tolerance, actually. Only about a fifth of them had impaired glucose tolerance. And the intervention or the study design for most of these trials that I'm going to talk about is pretty similar. So the lifestyle is a backbone for each arm. And then in this study, half the patients were randomized to placebo, half to the prescription strength Orlistat, and they were followed for 4 years. And the primary endpoint here was newly diagnosed diabetes as defined by an OGTT. So first here I'll show the weight loss data. So up top you have the placebo weight loss. Down here is the weight loss that was achieved with the Orlistat. You can see in both groups the max weight loss was around a year or so, and then there was some gradual weight regain. But there was still at the end of 4 years a statistically significant difference here with about 3 kilo weight loss in the placebo group and 6 kilos in the Orlistat group. And here is the data on diabetes. So we're looking at cumulative incidence of diabetes here. And first, I'll draw your attention down here to these bottom hash lines. The solid circles represent the placebo, and the open circles are the Orlistat. And you can see at the end of 4 years, there was a 37% reduction in the development of diabetes. This was across all comers of the study. So if you remember, about 80% of the patients had normal glucose tolerance. 20% had impaired glucose tolerance at the start of the study. So when they look specifically at patients who just had impaired glucose tolerance, that's represented up here. And you can see the effects were more profound with a 45% reduction in the development of diabetes among these patients who are probably at the higher risk for developing diabetes to begin with. So the next medication I'm going to talk about is called Contrave, which is a combination of naltrexone and bupropion. Alone, neither one of these agents are great at weight loss, but they kind of complement each other. So the Wellbutrin component stimulates POMC neurons to release alpha-melanocyte stimulating hormone, which promotes satiety and decreases food intake. And then the naltrexone prevents some rebound that can happen when you have this activation. The titration schedule is there, kind of work it up over a number of weeks. And then the main side effects include nausea, headaches, constipation. There is a warning about suicidal ideation with this because of the Wellbutrin component, and also because of the Wellbutrin, you need to be careful in patients who have a history of seizure disorder or eating disorder because it lowers the seizure threshold. So I am not aware of any studies that have looked specifically at the use of Contrave for the prevention of diabetes. So I'm going to show you some surrogate data that we have here from the Core 1 study, which was one of the main studies that looked at weight loss with this medication. Again, the study design was very similar. All patients had lifestyle counseling and then were randomized to placebo or intervention. 2 different doses of the Contrave were used here, and they followed these patients for a year. And this is the weight loss data, placebo up top in red, and then the 2 different doses of the Contrave down here. So you can see much more significant weight loss with the intervention group. And here are those surrogate markers that I mentioned. So as part of this study, they looked at fasting insulin, fasting blood glucose, and HOMA-IR measurements. And at least with the highest dose that they looked at, there was a statistically significant improvement in all of these markers over the 1-year time period. Now, whether or not that's clinically significant, I'll leave up to you to decide. For example, here, the fasting blood glucose went from, that's probably around like a 90, 93 or so, down to 90. So 3-point improvement in fasting glucose. But it was statistically significant. All right, moving on to lorcaserin, which is also known as Belviq. This is a serotonin 2C receptor agonist that works to decrease food intake and increase satiety. It can be dosed once or twice a day, depending on the formulation. The main side effects that I've seen are headaches. It's contraindicated in patients who are using SSRIs because of the serotonin component. And there was this question about the risk of development of valvular heart disease. Now, this concern was raised because of the debacle with fen-phen. If you remember, fen-phen was a medication that was approved for weight loss in the United States. It was taken off the market over 20 years ago now because of the development of significant valvular heart disease. Well, just a month ago in the New England Journal of Medicine, there was a large cardiovascular study done using lorcaserin with 12,000 patients, and they didn't see any increased signal for heart disease. One of the reasons that we think this is that fen-phen targeted the 2B receptors as well, which are on the heart, whereas 2C receptors aren't found on the heart. So in theory, there should be no increased risk of cardiovascular disease, and now we have some data to support that as well. So there were two main weight loss studies that were done with lorcaserin, the Bloom and the Blossom study. I'm going to show you the Bloom data here. Again, same study design with everybody getting lifestyle, randomized to placebo or intervention. The main follow-up was for 1 year in this study, but then what they did is they randomized everybody who was in the lorcaserin group to either continue lorcaserin for another year or be switched over to placebo. So this is what happened here. In the blue, we have the placebo weight loss up to a year. The gray and the orange bars represent patients who received lorcaserin for the first year. And then, like I mentioned, at the end of the year, half of the participants were switched over to placebo. And they're represented in gray here. And you see what happens is that over time, they regain their weight. And at the end of the 2-year period, they're indistinguishable from those who are on placebo for the entirety of the study. So this is common with most of the weight loss medications. They work great while you're on them, but those effects don't seem to be sustained long term. So I do always counsel my patients that I think about weight loss medications as a chronic medication, similar to an antihypertensive medication or something else because of this that we see. So with that cardiovascular study I mentioned, they also looked at prevention and remission of type 2 diabetes. So they had 12,000 participants. A little over half had diabetes at the time of enrollment. A third of them had prediabetes, and then the rest had normal glucose tolerance. And the primary endpoint for this part of the study was time to incident diabetes. And the data is shown here. And I should say that this is looking at this is looking at participants who had prediabetes or impaired glucose tolerance at time of enrollment. And so you can see at the end of the 3-year time period, a significant decrease in the incidence of diabetes in the lorcaserin group. This was a 19% reduction in the incidence of diabetes. Okay? So to summarize all of their findings from this study, like I mentioned, 19% reduction in incident diabetes in those with prediabetes at the time of enrollment. There was a 23% reduction in risk in patients without diabetes. And then amongst those with diabetes, they did see an A1C improvement of about 0.3. And then the last medication I'm going to talk about this morning is Qsymia, which is a combination of phentermine and topiramate. I'm not going to talk about Saxenda since you just heard about that in the last lecture, but that is approved for weight loss. And I'm also not going to talk about phentermine monotherapy, because although a lot of us do use it for weight loss chronically, it's not approved for long-term weight loss. So Qsymia, like I mentioned, is a combination of phentermine and topiramate. These medications kind of complement each other to promote satiety and decrease food cravings. There's a titration regimen there. You must be careful to taper it if you are stopping it. The main side effects and then the contraindications to be aware of. You don't want to prescribe this for anybody who's trying to get pregnant. Actually, none of these medications really should be used in that case, but topiramate in particular is teratogenic, and there is an increased risk of glaucoma as well. And this is data from the SEQUEL study, which is the main weight loss study with Qsymia. But they did a subgroup analysis of patients who had metabolic syndrome or prediabetes at time of enrollment. So similar type diagrams. So what we've seen, this is the incidence of diabetes in those with placebo versus those who received 2 different doses of the phentermine topiramate. And there was an 80% reduction in the incidence of diabetes at the end of the study period. And then for your reference on here, I put the respective weight losses seen in these groups. So the placebo group lost about 2% of their body weight, whereas the intervention group lost on the order of 11 to 13% of their body weight. So when they looked at diabetes incidence stratified by weight loss, not surprisingly, they saw that there was this dose response, if you will, meaning that patients who lose more weight are less likely to develop diabetes. So if you lose 15% of your body weight, you had about a 0.1 incidence of diabetes here. And this was irregardless of which group the patients were in. So if they lost 15% of their body weight on placebo versus 15% of their body weight on the intervention, didn't matter. Your incidence of diabetes decreased with both groups, suggesting that at least for these medications, that the benefit seems to be related to the weight loss and improvement maybe in insulin sensitivity, less likely to be related to any impact on beta cell function. I am aware of one mediation analysis that I think is going to be published in the next month or so, looking at lorcaserin. And they are going to be presenting data that they think supports some secondary glycemic effects. Only about 50% of the improvement in fasting blood sugar, or A1C, that they saw, they attributed to weight loss, but I haven't seen all of the data yet. And so I included this just for your reference. It's a good summary slide of the medications, the mechanism of action, the weight loss that can be expected, and the common side effects. And then this is just a summary that I put together of the medications that I discussed here, the trial names, and then the overall diabetes risk reduction that was seen in these various studies. So in conclusion, weight loss medications seem to have benefit and decrease the risk of progression from prediabetes to type 2 diabetes by about 38 to 79%, depending on which study and medication you're looking at. As I mentioned, it's not clear to me at this point that there's any added benefit above that which is attributable to weight loss, so probably no direct beta cell impact. And then I didn't have time to really touch on the cost of this. We heard a little bit about how cheap metformin is, but these medications are expensive, and like I mentioned, not often approved by insurance companies. So I think certainly it would be of benefit to have some cost analysis to balance the expense and efficacy of lifestyle interventions with these medications compared to other interventions such as metformin bariatric surgery, which we know has really great efficacy. And with that, I'll conclude. Thank you.
Thank you so much. And last but not least, Peter Gata. We're going to get him started with SGLT2s and diabetes. There you go, sir.
Okay, thanks a lot. So we will head back to the anti-diabetic agents. We will talk a little about the SGLT2 inhibitors in prevention of diabetes. Again, I have no disclosures whatsoever. What do we know about the effects of SGLT2 inhibitors in diabetes? Well, as you all know and has heard during these few days here, we have seen that empagliflozin and also canagliflozin can reduce cardiovascular mortality and morbidity in patients with type 2 diabetes. We have also seen that there are effects on microvascular disease, especially in the kidney. Unfortunately, we don't have a clue as to how these drugs actually work. We can just see that the effects are there, but we're not really sure what are the mechanisms behind these marked reductions in complication prevention. One thing that we can say is that especially for the SGLT2 inhibitors, the effects are almost as soon as when you start taking the drug. So it has to be effects beyond classical risk factor modification. Now I'm going to discuss prediabetes and prevention of diabetes. But in that respect, you have to know or remember that the empagliflozin trial and the canagliflozin trial were all performed in patients who were in high risk of complications. They had cardiovascular disease at the beginning, so they are no way the same patients as the ones with prediabetes. And of course, until now, we don't know whether the effects from the EMPEREG and from the CANVAS trial can be extrapolated down to lower risk patients. We just heard Abraham Thomas told you a little about the DECLARE-TIMI study, which was in fact negative on the original MACE trial. So maybe the effects will wear off the lower the risk you have. And once again, I showed you this slide Friday. When we talk about prevention of diabetes, what are we in reality talking about? Of course, if we take a drug that lowers glucose and we go beyond the limit for diagnosing diabetes, of course, you can prevent diabetes. But in my mind, what should be done is, of course, that we should change pathophysiology. If we can change pathophysiology, such as Abraham Thomas told us a little about with the GLP-1 analogs, where it actually seems that you can prevent beta cell deterioration. Now, this is my mind is prevention. And secondly, being a clinician, I'm always concerned about whether giving a drug, in fact, does prevent complications in the long term. I mean, there's no reason for giving a drug 5 years earlier if we, in the end, will have the same outcome. We have just wasted a lot of money, and maybe we have given some patient side effects to these drugs. So what is known about SGLT2 inhibition in prediabetes? Well, come back later because we haven't got a clue. There are no trials out there, so I could in reality stop my talk here, but I've been giving 15 minutes, so I'm going to use them. So instead, I will try and talk a little about how these drugs actually work, so we can see whether there are any changes in pathophysiology that could give us a clue whether these drugs could be used in prevention of diabetes. First of all, this funny name, SGLT2, is in fact the name of a small protein that is in the renal proximal tubulus. It stands for sodium glucose cotransporter number 2. And as you can see here, this is a small protein, a transporter protein that can take sodium and glucose from the pre-urine and take it back into the bloodstream. So this is in reality a mechanism that makes sure that we don't waste glucose in real life. The body needs glucose. We don't want to get rid of it. And as you can see here, normally we can go up to a concentration of around 200 milligrams per deciliter. It's a quite effective mechanism before we will lose glucose. We know from a lot of mechanistic trials that SGLT2 inhibitors, they have many different changes in many different parameters, as you can see here. Now, when we talk about diabetes, it is, of course, very interesting that we can lower glucose and that we can lower the need for insulin. But you'll also see here that there are some trials out there telling us that it can lower blood pressure, it may be able to change arterial stiffness, etc., etc., etc. But one thing is these small studies, of course, we need larger clinical trials to be able to tell anything about it. We heard an excellent talk about weight loss and how important this is in prevention of diabetes. And if we are going to look at something where we could say that SGLT2 inhibitors might actually prevent diabetes, we know that these drugs also are the cause of weight loss in these patients. And as you can see here, this is a study looking at dapagliflozin on body weight. You will see here we have patients randomized to metformin and placebo compared to dapagliflozin and metformin. And you will see here that there is weight loss in both of the two study groups here. But if we look at the division between fat mass and lean mass loss, you will see here that the weight that you lose during SGLT2 inhibitor treatment seems to be more related to fat mass. And as you might know, fat is one thing. We have subcutaneous fat, but we also have the visceral fat, which is let's say, the bad fat. And over here to the right, you can see here, this is now the white is visceral fat, and the dark one is subcutaneous fat. You will see that a larger proportion of the weight loss or the fat loss is due to loss of visceral fat. So that might be something that could be important in the future. Now, what happens in the kidney during treatment with gliflozins? As I told you, we reduce the sodium reabsorption, and we thereby increase the amount of sodium to the macula densa in the kidney. And we know that this has direct effects in the kidney. You can decrease hyperfiltration in mice, and it has also been shown in some patients or in some trials with type 1 diabetes that you can see or you can reduce the intraglomerular pressure. So there might be direct effects in that. Could that prevent diabetes? I don't know. I don't think so in any way. Now, a very, in my mind, interesting hypothesis as to how these drugs might work is these drugs' ability to increase the ketone level in the blood. If you have some of your patients who are on SGLT2 inhibition and you actually measure ketones, blood ketones, you will see that they are slightly elevated in all of these patients. And this might be due to this mode of action. Now, this is a cartoon telling us what happens if we take an SGLT2 inhibitor. As you can see here, it increases glucosuria, thereby reducing plasma glucose. By that, we will have a diminished need for insulin, which again will increase lipolysis, the fat will go into the liver, and we will increase ketogenesis, and thereby we will have an increased ketone level in the plasma. Also, by this lowering of sodium reabsorption, you will in fact see that instead the kidneys start to reabsorb ketones, and again you will have elevated levels of ketones, and there might also be a direct effect on glucagon. Glucagon actually increases in these patients due to the reduction we see in glucose, and that again gives rise to ketogenesis. Now, when we talk about diabetes, ketones, it's bad. That's how we have been taught for many, many years. But you have to realize that ketones is actually an excellent fuel for the body. In fact, compared to some of the other substrates here, if you go to the right side out here you can see how much energy is liberated when the body burns these different substrates. You'll see that ketones, apart from palmitate, is the best one. But palmitate a lot of this energy is just going into heat. So in fact, if you want to have the most efficient tool or fuel in the body, it is in fact ketones. And that might be the reason why it works so well in the heart or in the ischemic heart and the ischemic kidney, because the idea is here that you will increase the ketones up here, and when we have a heart with pure perfusion and thereby less glucose production or glucose formation in the heart, we will, by shifting to ketones, we will have a better machine. And it turns out that all of these SGLT2 inhibitors, they have a fabulous effect on heart failure. And it is quite interesting to see that already from day one, the first day you start taking these drugs, the curve starts to separate. So it doesn't take years. This has nothing to do with glucose lowering, blood pressure lowering, or whatever you have. So the idea is that if you give SGLT2 inhibition, you will increase the loss of glucose and sodium. By that, you will have an increase in the hematocrit, you will have lowering of blood glucose, you will lower the ECF, etc., etc. And in the end, this is why we see all these beneficial effects. But again, this is in high-risk patients. And this is just some of the mechanisms that we have already talked about that is listed here. So, are there any direct effects of SGLT2 inhibition on measurements of insulin resistance? Now, I talked about insulin resistance last Friday and about how we can measure it. Now, we don't have any human studies here, so we will once again turn into animal studies. And I know it can be a bit busy, this slide here, but the idea is that we have mice that are treated with different things for 4 weeks. You can see here the black one is the vehicle, which is the placebo group. And then we have, and again, the idea is that these mice, they can eat whatever they want. So the idea is that they would gain weight during the duration of time. And here you can see you give different weight-losing drugs, sibutramine, Orlistat. The blue one is empagliflozin alone. The red dotted line here is empagliflozin with sibutramine, and the green one is in combination with Orlistat. And you can see here, when you start taking these drugs, especially the weight-lowering drugs that we just heard about before, you will see a large decrease in body weight. This isn't as abundant when we look at empagliflozin alone, at least not in these mice. What happens to glucose? You can see it here. Again, the blue line is empagliflozin alone, but it seems like the more weight you lose, the better the effects on insulin production and plasma insulin levels. And finally, if we look at some measurements of glucose and insulin here, and I said these are mice without diabetes, but I don't really know what the levels are. These, if they would have been humans, they would have been diabetic. But anyway, what you can see here is as weight goes down, insulin goes down, leptin goes down, glucose goes down. So all the good stuff is going down when we lose weight. Here we have some specific measurements of insulin resistance here on the right side. And once again, empagliflozin alone, yes, it does reduce insulin resistance, but the more weight you lose, it seems like this is the driving factor. Here we can see body composition in the different mice. And again, if we look at fat, it's not much with EMPA alone. But again, the more you lose in total weight, the more fat you lose. So just to conclude, SGLT2 inhibition reduces blood glucose in type 2 diabetes by increasing glucose excretion via the kidney. We do see a concurrent increase in glucagon. This might be one of the mechanisms why SGLT2 inhibitors reduces CVD morbidity. However, we do not know anything about its role in diabetes prevention. If we turn to mice, we can see the glucose levels are lowered and insulin resistance is diminished. But again, this is probably due to weight loss rather than any direct effects of SGLT2 inhibitors. So most likely, if we are going to talk about diabetes prevention with SGLT2 inhibition, it might be secondary to the weight loss rather than changing any pathophysiology in subjects with prediabetes. But of course, we need clinical trials, so stay tuned and come back in the future. Thanks a lot. We are right on time.
Yes, I think that's
perfect.
Fabulous. Shall we have all 4 of the speakers gather in front for the discussion/debate? I'm not sure if Mahmoud is going to be debating much or not, but here, let me give you this.
Yeah, okay, yeah. Yeah, sure. And what about Mahmoud? We can just share, yeah.
Share the discussion.
Yes, Darren, yeah.
I can start out with a question. I'm an endocrinologist. Lots of primary care physicians especially send me a message. Well, what's going to happen to my patient? I'm going to check my patient's A1C again. And in people that they're attempting to prevent diabetes, they've defined some sort of pre-diabetes.
Well, for SGLT2 inhibition, no idea. Hey?
Though the studies didn't use A1C, and as we heard yesterday, the programs like the Y don't use the A1C. It is one of the screening criteria, so I actually don't think it's probably incorrect to measure A1C to look at the development of diabetes. The recommendations for screening are semi-annually. So I think for the purpose of clinical care, whether it's A1C that's measured not repeatedly like we do for diabetes or fasting glucose, those are probably the most practical. The oral glucose tolerance test is harder to do. And then I think what's important is we know in certain racial groups that A1C can be problematic. And we see that mostly in the US and African Americans, where the A1C doesn't correlate as well to the glucose. So you might want to do something else besides an A1C alone.
Yes? Checking fasting insulin? Yeah. Well, that.
So the question is, should we check a fasting insulin in the patients that Dr. Olson just talked about? And my personal opinion is I don't check fasting insulin levels in almost any patient, unless there's a reason, like I'm working them up for an insulinoma or something like that, because they're useful in research settings. But we really haven't have a good way of how do we use that in a patient that we're following for diabetes or pre-diabetes. We'll see a couple of things. Either we'll see higher insulin levels that are there to try and overcome their insulin resistance, or as they fail, their insulin levels will drop. So in a day-to-day, how do I take care of this patient? I don't think it adds much.
But then again, it really depends on the drug. I mean, the agents we have been talking about, metformin, GLP-1 analogs, SGLT2 inhibition, they don't cause hypoglycemia, so of course it's no problem. In fact, you can, as I showed you Friday, you can use insulin to prevent diabetes. And if I were to do that, which I am not, of course I would measure glucose, because as you could see, that heavily increased the risk for hypos.
Yes, I agree. Usually it's not measured, but let me tell you that you raised a very important point, because when it came to diabetes prevention, I do believe that the challenge is how to improve the insulin resistance. Maybe that's why I'm here to defend the metformin, but we will find that the TZDs are actually in the top when it came to diabetes prevention, I mean medication-wise. So the issue is usually the insulin resistance, not even the insulin secretion. And even for the drugs used to decrease the weight loss by itself could improve the insulin resistance. So I believe in a way she raised a very important point to measure the insulin level, because it could be hyperinsulinemia with non-functioning insulin.
But would you change your way of treating then if you knew? No. Okay.
It's not harmful to me, but usually it's not measured to my knowledge.
But then again, and I'm asking you because I don't know, would that increase the success rate for becoming pregnant if we did that? It would, because, because then again, we talk about preventing diabetes, and I showed the long-term data from the DPP Friday, and I mean, if you compare these patients 15 years after the start of the intervention, there's no difference in diabetic complications whatsoever. So in reality, are we doing any good by, for example, treating patients 15 years with metformin if it doesn't reduce complications in the end? I know it's a bit provocative, but still.
Though still with just polycystic ovary syndrome, the large NIH-funded study that looked at clomiphene citrate and metformin, when you look at live births, which is probably, I think, the outcome that people who would like to have children would have, is the clomiphene citrate was superior to metformin, though there was a tendency to having less multiple gestations with metformin. If you're looking at actually just getting pregnant, metformin is similar, but if you're looking at live births, clomiphene still is probably a better choice of agent. So clomiphene citrate, which they use for induction, but I don't know, if you need to, how insurance companies will view the insulin level as a reason to approve a drug. It's not something that when you have the forms that I've usually seen that they've requested, they're usually asking for other stuff. That's an important point.
And in the setting of PCOS, for evaluation for diabetes or pre-diabetes specifically, I am more inclined to send patients for an OGTT rather than just relying on an A1C in that population.
Okay, if nothing more, I just have a final comment. Someone asked me about the cost for metformin. How comes it's zero? Yeah, sometimes it's zero because I'm aware of so many pharmacies in this country are actually offering metformin for free, even without any insurance or stuff like this. Maybe, I don't know if you agree with me, the conclusion, with the exception of sulfonylurea, any diabetes medications may be used in the prevention of type 2 diabetes. Thank you.
Yeah, if we look at glucose levels
Yes.
alone, but still, I would, if I were to choose one drug, as you said it in the beginning, I'm not that fond of course, metformin is cheap, but I think that the GLP-1 analogs, they have interaction in so many ways of the pathophysiology and the development of diabetes. So when that will be a $0 drug in 25 years, perhaps,
But
the world is different, yes.
To acknowledge the effort of Ali, it's any diabetes medication and some of the anti-obesity medications may be used in prevention of type 2 diabetes.
Yes.
Okay, thank you so much.
Yeah, thank you. No, I was just saying the ones that the clearest are the ones
Yeah,
that are presented as the obesity drugs because they don't lower glucose by themselves, right?
No. Right.
So I think that's the easiest to interpret the change to diabetes. The other ones all lower glucose.
Yeah, exactly. Yeah.
Thanks. And our next speaker is Lucille Bessler, who's going to conduct a workshop of sorts on nutrition and diabetes prevention. And here we go.
Thank you. Good morning, everyone. So I think that you all are really great troopers for being here on a Sunday morning. I don't know about you, but I'm feeling like a little tired, right? So, and I'm sure that you have a lot of activity this week before Thanksgiving. So thank you very much for allowing me to be here today. I'm a registered dietitian, licensed nutritionist, and I also am a certified diabetes educator. I'm going to talk a little bit about what the Academy of Nutrition and Dietetics has gathered in their evidence analysis library. And then I'm going to talk to you about practical approaches to nutrition, things that I have found very helpful in my practice. And then hopefully I'll convince you all, if you are in practice, to hire a registered dietitian to really help you with your patients and to get some good outcomes. So I think that we have heard this morning, everyone understands one of the keys to preventing diabetes is managing overweight and obesity. And I'd again like to describe the role of the registered dietitian nutritionist in a multidisciplinary approach to obesity. So we know the facts. The facts are that this is the biggest challenge we have, the biggest risk factor to the development of diabetes is obesity and overweight. And it's costing us millions and millions of dollars, even billions now. So when we talk about drug costs and how much they cost, or we talk about nutrition services and how to get reimbursed for that, and everyone says, oh, that's expensive, we forget what the cost of obesity is. So this is something that we really want to talk about. So we all know this, right? Cure obesity, cure overweight, and perhaps then we reduce the risk of diabetes and we prevent diabetes. So it's really easy. We all know this. But what makes it so difficult? It is really difficult because it's basic, but behaviorally, it's very complex. We do know that there are many causes of obesity, many causes. So there's genetics, there's socioeconomic factors, and then there's dietary factors. So is it just the food we eat? Is it also how we prepare food? Is it also food availability? I don't know if any of you walked downtown yesterday to the Emory Central. I think that's what it was called. You know what I noted? There was this gorgeous supermarket. And if you peered in, you could see that that supermarket would have lots of good fresh vegetables and different kinds of fresh food. And what? It was closed. So I asked someone, when did that close? They told me April. So food availability is really important. I was talking to someone, and they live in a rural area, someone who was at this meeting, and she told me it's a half hour to a store. So the Super Walmart is the most popular store a half hour away. So what do people do if they're going to go, if it's going to take them a half hour? They're going to load everything up, right? So it's not just the composition of our diet. We have to remember it's food availability. Are you living in an area where there is not access to good, wholesome food? So I have to say, I think there's no shortage of position papers on the best practice, the most scientific-based practice for nutrition. So we have a couple of really good position papers. Last week I went to the obesity conference in Nashville. I don't know if any of you had attended. And it's a whole week. It's called Obesity Week, which brings many health professionals together to talk about this complex issue. So endocrinologists, bariatric surgeons, dietitians, nurses, ARNPs, the whole gamut of how can we really address this epidemic, which is really causing many of these chronic diseases, especially diabetes. So these are some of the position papers, and what's really great is many of the associations are coming together and actually coming up with consensus and position papers, very much like the position paper that was presented to you on Saturday. So what I'd like to do is talk a little bit about the Academy of Nutrition and Dietetics, our evidence analysis library. So if you want to get access to it, if you're a member of the Academy of Nutrition and Dietetics, you get access to it. If you want to become an associate member, you can get access to it, or you can just hire a dietitian and they'll have access to it. So what actually we have some information on is there's three studies that we're looking at to see if there is strong evidence that weight reduction through different means can help individuals prevent diabetes. So for individuals who are at high risk for type 2 diabetes and they're overweight or obese, then a registered dietitian nutritionist using evidence-based guidelines should be providing a weight-reducing diet. So for fun, later on in my presentation, I'm going to talk to you about the hottest diets, right? Because everybody hears about the hottest diets. Everybody tells me, so what about the keto diet and the paleo diet and all these things? But, you know, to us dietitians, we don't kind of really use fad diets. So we're really looking at a weight-reducing diet using the recommendations of the American Diabetes Association, the Academy of Nutrition and Dietetics, the AMA. So in adults with metabolic syndrome, when they were able to achieve a weight loss of anywhere over a 3-month period from 1.1 kilos to 13 kilos, which is pretty significant, we were able to see a decrease in hemoglobin A1C by 0.12 to 0.3%. There was a decrease in triglycerides by 20 milligrams, and then a decrease in waist circumference, which we know is one of the really most important factors when we're looking at anthropometric measurements. And then we saw a decrease in blood pressure. So what did we find here? This weight loss program was a lifestyle modification. It was a 12-week weight loss program where individuals received counseling, education, and ongoing support. So somebody mentioned the diabetes prevention program, and that's very much what the diabetes prevention program. It's education, it's support for a long period of time. Does anybody heard about the What Can I Eat program that the American Diabetes Association has started? Well, that's a really neat program too. And that's a little bit easier than the diabetes prevention program because it's a 4-week program. So individuals for 4 consecutive weeks will get education and will learn what they can eat. And this is for diabetics, but I thought it's interesting if you all know about it. Our office has a grant from the American Diabetes Association to conduct this, but if anyone is working with diabetics before that pre-diabetes and you want to do it, you might want to contact them. Okay, then we saw individuals with pre-diabetes achieve weight loss via bariatric surgery. So in our practice, we see a lot of individuals that are trying to qualify for bariatric surgery. And in this review, there was 47 kilos on an average that these participants lost, or 41% of excess body weight. And this was reported over a 3 to 5 year period. And what we saw was a decrease in the fasting glucose levels, which you could guess that was, and then a decrease in the 2-hour postprandial, and a decrease in the hemoglobin A1C, triglycerides, and HDL. So we know that individuals who can qualify for bariatric surgery and have it and are successful, it reduces their risk of prediabetes and diabetes. So then in the last group, we had a weight loss achieved, again, through lifestyle modification for a 3-month period. And this was ranging, their weight loss ranged from 2.6 kilos to 7.1 kilos. In this group, they used the Mediterranean diet, and we'll talk a little bit about the Mediterranean diet. And again, we saw that decreased fasting glucose levels by 2.2 milligrams, a decrease in triglycerides, waist circumference, and blood pressure. So I think that we all are pretty certain, and we know that from all our research that weight loss is what's going to help with decreasing the risk of diabetes. So, but how do we design programs where people are successful? because we know this, but I said before, yeah, okay, we kind of know that if we could get individuals to lose weight, if we can combat the obesity epidemic, then we're going to really make a dent in diabetes. But how do we do that? So, of course, I say, I have no disclosures, but I'm completely biased because I think a multidisciplinary approach to weight loss and to education is really important. And I also believe that it is important for endocrine clinics, primary care clinics, to embed that registered dietitian nutritionist in their programs so that we can get the best outcomes. We want to make sure that the design is a good design, and it's easy for patients to follow. So, you know, I hear often about patients that go to doctor's offices or endo offices or anywhere, and they're given a sheet of paper. It happens all the time. I love when they bring me the sheet of paper, and I see a sheet of paper that was Xeroxed 20,000 times, and you could barely read it, and this is what they told me I need to eat. So that's not a good design. Handing a patient a piece of paper and telling them, don't eat this and you could eat that, is not a good design. We need a good design using science, and that's really important. We have to collect outcomes. So that's another thing. And you know, we have done that in our practice. So in our nutrition practice, we were able to determine with 3 visits, 3 comprehensive nutrition visits, we were able to lower hemoglobin A1C by points. That was really great. So we had people from 8.6 down to 6.6. But again, that was the comprehensive education. We need to report outcomes, and then we need to know patient satisfaction. So we saw slides before that individuals in weight loss plans, they don't stay too long in that weight loss program. Why? Poor satisfaction. Are we meeting their needs? Are we just giving them something and saying, follow this? But are we really working with them to see good success? And that's something that I think that we forget. And that's where your registered dietitian nutritionist comes in, because that's their job. That's what they're supposed to be doing, providing nutrition assessment, providing nutrition education, and then providing ongoing support and resources for these individuals, all the while using science evidence-based practice. So I'd like to say to you, I think the biggest area of health fraud is nutrition. Does anybody agree with me? Oh, thank you, thank you, thank you. Okay. So, you know, when a real estate agent who now is dubbed the, I don't know what she's dubbed, the diet gal or the food lady, and she tells people not to eat this and not to eat that, and she has 2 million followers, and I don't have that many followers. I think I have about 2,000. So nutrition is a big area of health fraud. So as health professionals, all of us, we have to hold the line. When people are coming to us and saying, well, you know, I drink apple cider vinegar and I know that's going to prevent my diabetes, we have to do this like, okay, well, I don't see any science. Let's look it up. And it's not Dr. Google that's going to tell us that that is good. So remember, your patients, when you say you're pre-diabetes, you need to do something, don't eat carbs, that doesn't help. They don't know what that means. So the big questions always are, what can I eat? But I thought it was healthy. I ate 6 bananas. I thought they were healthy. The internet says, and my neighbor says. I always like that when my neighbor says, you know, I don't know about you, but sometimes at the end of the day, after seeing about 8 or 10 patients, I kind of get a little grouchy at the end of the day. I'm not admitting it to my patients. I'm going to admit it to you a little bit. So when they say, my neighbor says, I want to say, okay, is your neighbor a doctor? Is she a nurse practitioner? Is she a nurse? Is she a pharmacist? What is she? So, but that's the bubble in my head. I never let that show. But these are the things that our patients are struggling with. So how can we prevent diabetes and help them if we're not giving them good information? So I like to say this. I coined this, and I want everybody to use it. Nutrition is a science. It's not a fad. It's not another way for an actor or actress to sell another diet book. So we always have to go back to the facts. And, especially now when we're looking at obesity being such a health problem and prediabetes and diabetes, we have to get to the facts. So the best diet to control diabetes and to initiate weight loss, the easiest, the best, the DASH diet or the Mediterranean diet. So I'm sure a lot of you like that idea of the Mediterranean diet, right? That's really great. And we know, what do these diets have in common? I'll show you pictures of them. But they really are sometimes, as health professionals, we know the basics. It's complex, high-fiber carbohydrates, lean protein, and good sources of fat. So I'd like to talk a little bit about fad diets, because I think this is kind of fun. Because you hear this in your office, and you're like, oh, okay, what's going on here? So, you have the keto diet, you have the paleo diet, clean eating. I love that. I like when people come in and they say, I eat very clean. I don't know why I have prediabetes. And I think, okay, that bubble in my head again, I say, as opposed to eating dirty? What's dirty eating, So that's the big one. I eat clean. The other thing is I juice. And, I love those pre-diabetics or diabetics who think, I'm juicing, and I took that 6 bananas, and now I'm drinking them down. And why do I have poor glycemic control? Okay, did we maybe give too much carbohydrate at once? Okay. And then, of course, gluten-free. Everybody thinks they should be gluten-free because, that's going to cure prediabetes or diabetes. Low sugar, nothing wrong with that. Detox, that's another one I like. When people say to me, I came here so you could teach me how to detox. And I think, oh, I'm sorry, is there something wrong with your liver or your kidneys? Because that's what detox is, okay? And then, of course, the alkaline diet that Tom Brady promotes. He didn't do very well. I was in Nashville last week, and they were very happy that they sacked the Patriots. So the only thing that I put a little question mark was vegan. Is that a fad diet? And I put a little question mark, because it's not. We saw yesterday a plant-based diet. As we well know, there's plenty of studies to show that it reverses heart disease and it can reverse diabetes, plant-based diets. So the more we can encourage people to do that, but that's not so easy. So why did I put a little question mark with vegan? Because sometimes I think people just get on the vegan bandwagon because they think it's a good way to lose weight. That doesn't necessarily, if you follow a vegan diet, means that you're going to have a low-calorie diet, does it? We kind of know that. So that's why I put a little question mark there for you. So what's really good? I mean, again, for health professionals, we think, oh, come on, this is really basic. But I see people in my office that are CEOs of companies. I see people who are from all walks of life. And sometimes I'm always really, not sometimes, most of the time, I'm really surprised when people say, okay, what's a carbohydrate? So we can't assume, kind of remember, I don't think we're getting any courses in home economics, right? I know my nephews, they can't, oh my goodness, they can't put together a meal. They're in their early 20s. If it doesn't go out of a box into another box, the microwave, they don't know what to do. So let's not assume people understand this. They don't. They don't have the skills anymore. They don't have the cooking skills, and they don't really have the knowledge of how to put together a meal. But we want to get back to basics if we're going to combat this obesity epidemic and then also help with reducing diabetes and preventing diabetes. So back to basics: vegetables, fruit, lean protein. It could be animal or plant. That's fine. Whole grains and small amounts of mono and polyunsaturated fats. You know, the big one is in my area in South Florida. Everybody loves coconut oil. They'll rub it on their body and drink it. So we have to try to convince people, wait a second, maybe that's not the best fat. And sometimes we have to spend a little time talking about this. Now, I know the doctors that I work with that refer to us, they don't have a lot of time. They'll always say, Lucille, we love to send you our patients because we know you and your team have a lot of time to spend with them to educate them. And I know that doctors don't always have that time in this HMO world. If you're going to hand anything out, then really look at the Mediterranean diet. The Mediterranean diet is really the best approach and the easiest for people to embrace. It's not hard at all. It doesn't tell them they can't eat some of the things that they like. So what makes the Mediterranean diet a little different? It's increasing their consumption of fish, which that's a funny one because people come in and go, I hate fish. That's not one of those things that you could try to like when you don't like fish. I'm worried right now in South Florida. We have a lot of local great fish, but we also had been hit with red tide. So I think it's interesting for us to know, well, how affected is the fish then? If you go deep water, is that okay? Is the red tide only on top? So these are things we have to think about. Maybe in your community, what do we do about if waters are contaminated? But we do want to have 2 to 3 times a week fresh and wild-caught fish. We want legumes or seeds or nuts. And those are the great things that really help with glycemic control, too. So different kinds of legumes. And you know what? I always tell people, any color, it doesn't matter. So it could be lentils, it could be white beans, it could be black beans, it could be the gamut. And, there's always, what Instagram is good for, everybody knows? Recipes. They got a great, Pinterest. They got great recipes, so they can always Google some recipes. I also like a plug for dlife.com. If you are really stuck for any of your patients and they say, but I don't know how to cook, I don't know how to make food, send them to dlife.com. Has the greatest, most robust recipes that they'll find. Easy to do. Recipes should be 5 ingredients or less now. It's kind of like we write education material for 3rd grade, and we make recipes 5 ingredients or less. If you use 5 or more, you're a gourmet cook nowadays. So obviously, we want to increase our, make sure that we have some fresh fruit and vegetables. Now, again, you might think, oh, okay, so this is so basic, Lucille. But I see people every day and talk to them about their nutrition. And I will tell you, they think lettuce and tomato is a super duper vegetable. And if they eat it 2 times a week, they're doing a good job. I kind of tell them they're not keeping the farmers in Florida in a good state. So, or they'll say things like, well, my family has diabetes and I'm at risk for diabetes, so I don't eat carrots. Okay. So my corny joke is nobody ever got admitted to an ICU because they ate too much carrots. So this is what we're looking at. Easy, not hard. We decrease our intake of animal protein and we increase our intake of complex carbohydrates. Difficult? No. The DASH diet. The DASH diet is the same thing as the Mediterranean diet, with a little bit more emphasis on lowering our sodium intake too, which is really, obviously very important for blood pressure. And that's really hard for people. I love talking to people and they say, oh, when I go to this restaurant, if it doesn't taste the way I want it to taste, I'm going to, get that salt shaker, right? And when you talk to restaurant, the development programs of restaurants, I went up to Darden Foods. They have a test kitchen in Orlando, and it was really fun. You got to meet all the chefs. And so, of course, as dietitians, we're giving the chefs a hard time. Why is it so high in salt? Why is it so high in fat? So they said, you have to understand, once we start diminishing the salt content of recipes, then all of a sudden people are not ordering these items. So they have to do it in an incremental fashion, but they are doing it. So they start with this is a 3-year project to get their sodium content of their menus down. I think it's really kind of interesting when we look at that. Now, there are some restaurants don't care. They say, we're not in the health business. That's not our thing. We're not in the health business. Other restaurants are really concerned, and they want to have something to offer their customers that could be more in line with what they need to eat. So this is my perspective. What do people need? They need, from my perspective, they need something that's fresh. So, people will tell me all the time, oh, but fresh food is really expensive. I had this conversation with somebody at breakfast this morning. They'll tell me that all the time. And I will tell them a box of cereal costs $5. A bag of apples during apple season, which is now, does not cost $5. So if you give me $5, I could plan a meal that's wholesome, that is within our guidelines for calories, within our guidelines for carbohydrate. We have to empower people with these tools. But why do they think it's hard? Because they don't have the basic tools of how to prepare a meal or, how to plan a meal. So they do need fresh, but they need fast. No one cooks anymore. How many of you really cook every day? Wow. Okay, you and I will just hang out together, right? I love to cook. I just love to cook. It doesn't matter what time I get home. I just love to cook. It's like a stress releaser for me. But most people don't have the time, right? You just don't have the time. So if you don't have the time, do you think your patients have the time? Nope, they don't. So again, us relying on convenience foods, fast foods, is probably, if we say a causative factor for prediabetes and diabetes, is obviously our diet. So we have to think about, okay, how do we make healthy food fast? So we empower our patients to do some prep. And now people are getting into it. They say, Lucille, I do all my prep on Sunday. So that's a fancy name for, or a fancy word for, cutting up and chopping vegetables on Sunday night so you can use them on Wednesday. But it sounds very fancy, right? Planning your menu and telling your patients that, why don't you sit down on Saturday or Sunday, have a menu planning meeting with the rest of your family, sit down, have ideas. Everybody gets their favorite meal. If meatloaf's your favorite, then maybe you can make that meatloaf on Sunday and cut it up and freeze it. We need to give people ideas about how they can be successful. I don't know about where you are, but in my area, all these pop-up places, fresh meals, fresh delivery meals are occurring. And that's really interesting. It's very expensive. It's the same thing as, what's the meals in the box? Help me out. What's the meals in the box? Blue Apron. So when I saw Blue Apron, I just thought, You know what? I should preface this. Don't ever ask me about companies for stock tips. I never do well. So I look at Blue Apron and I say, who would do that? Who would order that and get 1 carrot? I want to buy a bag of carrots, because if I feel like putting a lot of carrots into my chicken soup today, I'm going to put a lot of carrots in it. Maybe I don't want so much another day. But look what I know. It's so popular. But it is a really good way for people to learn how to prepare a meal, to plan a meal. And will that help them? Yes. Why? Because it's 1 carrot. It's portion controlled. And we know the whole key to this, when we look at drug therapy, when we look at these things, what is the key we're looking for? Reducing our intake. And that's the hardest thing. That is really hard. So portion control, if we teach any one of our patients anything, it's portion control. And don't think that insults them in any way, insults their intelligence. I hand out portion control, different plates, culturally diverse for so many of our patients. And you know what? Again, it doesn't matter their socioeconomic status. They love it. And they say, oh, okay, I get it. This is what I am supposed to be consuming. So this is what what consumers think they want. So everybody thinks they want non-GMO. That's a talk for another time. Organic. So people will tell me all the time, but I eat organic. That's clean and organic. Okay, so good. That's good that you eat organic, but, you know, eating 20 ounces of organic beef is still not a good idea, right? So what they really, I feel, again, what they really need is obviously easy, healthy, and nutrient-rich foods. And that's what we're not getting to. And, you know, all fun aside, when we talk to people, we know they might be getting the calories they need, but they surely are not getting the nutrients they need. So we are looking at people who are overweight and possibly pre-diabetic and might be malnourished at the same time. They might not be getting adequate protein. They definitely are not getting adequate vitamins and minerals. And this is a big issue. When somebody never eats vegetables, never eats citrus fruits, never eats other kinds of fruits, how are they getting those vitamins and minerals? Oh, they'll take a pill. So that'll be okay, right? But we know. So I think the whole key is there's no magic formula for weight loss, and there's not even that magic pill, right? None of those pills seem to be really magic. And I really like what was said before. Can we, with a comprehensive weight management lifestyle approach, can we get the same outcomes without drug therapy, without the cost and possible risk of drug therapy? But we have to always still go back to our nutrition science. That really is the key. So if you want to find a registered dietitian for your practice, I would really encourage you, because everything I talked about today, you can have that licensed health professional talk to your patients about. The good news is it's reimbursable. Many insurance plans now cover nutrition services by a registered dietitian. So embedding them into your practice would be a really good way to improve outcomes, improve your bottom line at the same time. If you just want to find somebody in your community, you can go on this site and put in your zip code, and you can find a dietitian in your community. So, you know what I kind of like, if you are going to refer to a registered dietitian, which I hope you will, there's a couple of things that I like to tell people. Don't do this. Oh, you gained 20 pounds. Okay, now you've got to go see the registered dietitian. Well, you know what? That's like a faith worse than death now. They come into our office like, oh. I say, why are you here today? And, they'll say, oh, my doctor made me come. I go, oh, okay, well, maybe you'll get something good out of this. So remember, make it a positive effect. You know, make it have a positive approach and say that there's going to be a good outcome from it. And we want to make sure that we're part of that multidisciplinary team. So your dietitian should be communicating to you and you communicating to them if there's anything special that you want them to know about your patient. Don't say 1,200 calorie diet. We could figure out what we need to do with the patients and if we have their medical condition. So if you need further information, if you'd like to access the evidence analysis library, or if you have questions for me, I'm happy to answer them. If you really do want to know how to embed a dietitian into your practice, I really would love to help. I think the take-home message is preventing diabetes, dealing with pre-diabetes. It's all about weight control and about nutrition based on good science. Thank you very much.
Any questions or comments?
Thank you. Oh, a couple. Okay. You're going to stump me on a Sunday morning? Oh, farm-raised fish. Oh, this is a tough one, you know, because I think if you read some of the papers on farm-raised fish, some of them are fed quite a lot of antibiotics. So what comes to mind, I read an article in Bloomberg that really made me crazy about shellfish, and so I will never buy shellfish out of the United States anymore. There's farms in parts of Vietnam and China where shrimp is being raised, and they do feed them antibiotics that are not found in this country and are not considered safe by the FDA. How they get around the origin. So like if I go to Costco and I say, oh, okay, I'm not going to buy any shrimp from China or Vietnam because they're using this, they can move that shrimp through different channels and it comes out of Ecuador and they'll put the origin as Ecuador. After I read that, I wasn't so crazy about like, oh, farm versus wild. But after I read that Bloomberg report, it was a really comprehensive report. I got very nervous about that. So I really do prefer wild, and I do prefer North American fish. Does that help? So, you know, again, we got to go back to the science. So that's what I try to do. You know, I might have personal opinions about things, but, you know, as a health professional, just like all of you, I really try to look at the science and say, this is what science says. My personal opinion is when I go to the supermarket. So the science says that organic is not better in terms of the nutrient content than conventional. Now, you might say, I don't want conventional farm products, and that's okay. The only thing I kind of caution people, if that's your view and you tell your patients that, remember, they might not have the money to buy organic, and then you put them at risk, or you give them an impression that if they don't buy organic, it's not any good. So maybe what we really have to concentrate on, too, is washing our fruit really good and washing our vegetables really good, which we don't anymore. Because we buy this stuff and it says triple wash. Okay, somebody else washed it for me. I don't have to wash it. When we really should be doing that and diminishing then any preservatives in there. But that's a difficult, I think that's very personal, but when you look at the science, that's what the science says. I never think anybody's getting all their vitamins from their diet. I mean, really, let's be realistic. So, but, you know, that's what I do. So I would do assessments on individuals, and I know if they have this kind of condition, they might need more of this vitamin. But if you're not doing that, I don't think a multivitamin with minerals would be very harmful. You could always, prescribe it once every other day. You know the toxic vitamins that are harmful. The toxic vitamin is vitamin A. You don't want them to be taking mega doses of vitamins. So if they come to your office and they put a shopping bag on your desk, which sometimes they do, with 20 different vitamins, right? 20, but you could save a lot of money because this B12 is in this multivitamin. But you got to take that time to go through it. A multivitamin with minerals is fine. It's never going to, I don't think it's going to hurt anyone. And I will tell you, as a dietitian, I would love for everybody to get their nutrients from food. Do I think that we do that? No, I don't. In South Florida, you would think that we get so much vitamin D and that nobody would be vitamin D deficient, right? Everybody's vitamin D deficient. Why? Because we don't really eat a lot of dairy. We might eat cheese, but do we really consume 3 servings of dairy a day? Probably not. So I always think there's room for trying to improve the diet. But if you think somebody has a problem, I don't think it's a big issue. You're right. I think that's such an important factor when you're talking to people because a lot of times, and studies have shown that many people consume 60 to 70% of their calories after 3 o'clock. So, let's kind of think about in terms of common sense, again, using that common sense approach. If I didn't eat from last night to 3 o'clock in the afternoon, you can't hold me back. I'm going to attack the refrigerator. So it doesn't help that portion control. It doesn't at all. Does it help utilize calories well? Well, in our diabetics, we know it does not help glycemic index, glycemic control. So those are some of the issues. I think that's really important. But then we have the opposite is that people who eat every 2 hours. I don't know where they work that every 2 hours they're taking a break to eat. But it's like, I have to eat every 2 hours to fuel my metabolism. Go take a walk. That'll fuel your metabolism. And not making it a walk to the kitchen all the time. Shame on me. Got to have fun. It's Sunday morning, right? Yes. So I tell them 2 things. I acknowledge that they are always hungry, because that's really, people get really grouchy if you say, no, you're not hungry, get over it. No. And they are always hungry, because we know those fluctuations in blood sugar make you hungry. So I always tell them, you don't have good glycemic control, that's why you're hungry all the time. So let's work on getting good glycemic control. But there's other little tips too, kind of little things. I always tell them, why don't you use fiber? You could take something like Metamucil or Benefiber. I don't have any stock in those companies. And you put it in water and you drink it a half hour before meals. It kind of fills you up a little bit. And that's just that whole fiber thing. But you do acknowledge that and say, okay, how can we build that meal plan so that you are not hungry all the time? I find it's when they skip meals. I find when they also are not really balancing a good amount of protein and complex carbohydrate. Mm-hmm. Right. So, right. So we could have those comparisons and discussions. My office is across the street from a super Walmart. So as my accent gives away, I'm not originally from South Florida. So when I walked into a super Walmart in South Florida, I was like, what the heck is this? And then somebody saying hello to me, I'm like, I'm from New York. Don't say hello to me. You know? But I will tell you, they really have cornered the market on bringing down the cost of produce. Now, some people are very anti-super Walmart, but I'm just going to say my experience. In this community, they also have lots of organic food if you're looking for that organic. But I do think, yes, it's convenience foods that people want, or they're foods that they want to feel really full, that's going to be really cheap as opposed to other healthy foods. But again, I think if people have better cooking skills, and again, I'm going to say I could buy a bag of lentils, and that's going to be less than a loaf of bread, less than maybe a frozen meal, and make a meal out of that. But that's because I might have those skills to do it. So I agree with you that there are times when the unhealthy food seems to be the most appealing and a little bit more cost effective because it's more filling. But I think if we had better skills, then we could combat that a little bit too. But I think that's a really good debate. I think so. I loved home economics. Yeah. You know what I think so. You know what I always am kind of amazed when people say to me, oh, I hate cooking. And I think, you know, I'm kind of a creative gal. And like I said, I love to cook. I've been cooking since I'm 5. My Italian grandfather taught me how to cook. And I just think it's like a really creative thing to do. And I feel, you know, bad when people say, oh, it's such a chore. We have to make it a little bit more enjoyable and fun, though. I agree with you. Yeah. Yeah.
Can I ask a couple of things that you could address following up on what you said? One would be about best practices for people that are not dietitians, and the other about perceptions that may follow unintended perceptions. The first, so you don't have the time, you don't have the, may not have the knowledge base, you may not have the desire to demonstrate to a patient what a new diet will be for, or a new eating pattern will be for the patient. So what would be the best practices for just addressing what you said is the most important, which is portion control? The next is, lots of people see dietitians. Dietitians, I think, are probably, as far as I know, are doing like you said. They come back and they say, you said, what did you learn? What did you hear? They said I could do more of this. They focus on that word more. They said, I'm doing more of this. I'm doing more of this. But you say, but the intention is not to do more in most of our patients that are addressing obesity or diabetes or something like that. So how do you...
Okay, so I don't know I can answer that second question on more because everybody's counseling technique is different. And what patients hear, as you well know as a doctor, patients hear and do something different. So I'm hoping that most dietitians are using science evidence-based and they're giving them practical approaches to portion sizes. For the non-dietitian practitioner, I think the best thing is to get really good resources and hand out at least resources to your patients. You can always get that food pyramid, the Mediterranean, or you could get a plate method. And there's the Diabetes Association has wonderful handouts that will actually show that plate method. So if you can't do anything else to say, make your plate look like this, that will be helpful in terms of portion control. But giving them at least some resources. That dlife.com, that's a great resource. That's an online website. Great articles, lots of different kinds of recipes for them, lots of nutrition articles. So if you can't do anything, then at least that. Right. Yeah, that's a great one, too. Thank you for sharing that. That's a really good one. Thank you all so much. I really enjoyed meeting you all.
We're going to have a break now until 11:30, correct? Okay. All right. Thanks.